Has started. Okay. So yeah, I mean it's honestly the key to being really good in this, and once you do this, but the key to being good is to work a team. And a couple things that they focused there is that things get bad, it build those relationships, and if you build those connections, not going to be as stressed, and you're going to together because it's very easy to fall apart, as things to go bad. So, one of the things I encourage you all to do slow is to talk relationships with each other. Just sit there looking at a screen all day. Get to know each other. Get to know families. Get to know their problems and things like that, so that you're aware. Important to do that. Again, that's only going to help. When you have times of stress, the dog's dying or whatever, you guys well aware of what each other are like and everything like that. It's just going to benefit you immensely. And then leadership. It talks about leadership and trust, and kind of puts those two, I think, in two separate categories. But to me, they're kind of the same thing. But as a doctor, as a technician, that would be someone who might be in charge of other technicians. You be a senior technician. I have a leadership role. If you know these people and them, and they to trust you in your leadership and your ability, get them to do what you want them to do. If they think you're going to give them good information, that is the correct information. And so again, just kind of being aware of what your strengths and weaknesses, and having that connection with them, so they know who you, type of person you are, is be huge. And see, as you develop this concept, sell you to relationship, whether it's team or whether it's business, it will only instantly benefit you. I think a lot of times, again, we focus on just knowing a lot of medical knowledge, and that being the only thing. And really what we need to focus on sometimes too is, because we're only as good, always better in a team. Who's ever done anything great things by yourself? But most things that are great team approach. There's a hospital I know that's shutting down right now, and I think it's primarily because of just nobody cared. The It's better. Show about kick. So I talk about shock, and concepts of shock and classification of shock, and just go over a little bit of this. I'm going to. I didn't start without you. So I'm just saying I'm going to talk about you there, Joe.
Yeah, your audio was cutting out a lot. I don't know if it
Was
was my
it?
computer. Yeah, so I restarted mine. I'll let you know if it's worse.
Yeah. If it's bad, let me know, and then I can change the way I do the audio. I'll change my volume and see if that helps.
Okay. All right.
But
Cool. Thanks.
yeah, if it's let me just close my door too. Like what I can do is, if it's really bad,
It seems
I'll put
maybe it's better now.
okay, I'll put on a headset if it is, and then I'll talk louder.
Okay.
Okay, so we're gonna talk about shock, some concepts in shock, and classification of shock. So a couple things you want to do is just kind of, this some of this stuff is real dry. I'm sorry. Some of this stuff is real dry, but I do think if you have a good understanding of it, of some of the shock concepts, it'll give you a better understanding of how we treat shock and how we classify shock, and when you use fluids versus when you go to vasopressors, when you use things like positive inotropes. So one of the key concepts you need to know is concept of oxygen delivery, and one definition of shock is decreased oxygen delivery. So what is the equation for oxygen delivery? I don't expect you to memorize this, but it's oxygen delivery is equal to cardiac output times the content of arterial oxygen, or the concentration of arterial oxygen, right? And it's somewhere between 500 and 800 milliliters per minute per meter squared. So we know that cardiac output is equal to the stroke volume times the heart rate. In other words, we have a certain amount of volume in the ventricle, and we push out, 10 mils. And if we push out 10 mLs 6 times every minute, then we pushed out 60 mils per minute. A lot of times we'll do it in milliliters per kilogram per minute, so you'll divide that, by the kilograms. But and so it's an amount per kilogram of body weight, but that essentially is what your cardiac output is. Your arterial oxygen content is based on how much oxygen is on the hemoglobin, which is this hemoglobin times 1.34 times the saturation of oxygen, which is, somewhere usually between, somewhere above 94%, or usually around 98, 99%, times the amount of oxygen that is dissolved in the fluid in the blood, or in the water in the blood, which is this PaO2 times 0.003. We know that most of the oxygen is carried on the hemoglobin. That's your larger number. And it's somewhere between 16 and 22 milliliters of O2 per deciliter. So again, when you take this number here, how much blood you're pushing through the body every minute, and when you take about how much oxygen is on the hemoglobin, and you multiply those two times each other, that gives you how much oxygen you're delivering to the tissues. Sometimes we'll look at the venous oxygen content, or we'll look at the difference between the arterial content and the venous content. That's how much the tissues took up, and that's a measure of VO2, or oxygen consumption. I like this definition, so not so much what is oxygen delivery, but it's a decreased tissue blood flow is another way you can look at it, and that's the definition that we're going to focus on here, is that shock is defined as decreased blood flow to the tissues. Now, that's not 100% right? I'm going to use that definition for this talk, but that's not 100% right, because sometimes you can have normal blood flow, but you don't have enough red cells, and that technically is shock. Or sometimes you can have a patient that has hypoxia from not getting oxygen into the bloodstream, and so they're not getting enough oxygen that way, and that technically is shock. Our cat that we have with the Tylenol toxicity, that methemoglobinemia, would technically have shock from not enough oxygen carrying capacity. But again, normally when we think of shock, we think of decreased blood flow, and that's a definition that I'm going to stick with here, and that's a definition that will help us in this lecture, and I'll explain why in just a second. The other thing too is sometimes you can have decreased blood flow from vasoconstriction to one area, and or sometimes you can have vasoconstriction decreasing blood flow area that's helpful, and sometimes it can be harmful. So again, decreased tissue blood flow generally is a bad thing, generally indicates shock, but sometimes we'll see it can be a helpful situation if it preserves blood flow to other areas. So again, for this talk, when I talk about shock, I'm going to be meaning that they have decreased, blood flow to the tissues. But that's not 100% correct that that's the only reason for shock. Sometimes there can be other reasons why you have decreased oxygen delivery. And sometimes that decreased oxygen delivery is actually a good thing, and not, shock, in other words, to some areas of the body is not always bad. So why do we focus on that? So this lecture focuses on decreased blood flow, the definition, in particular, global decrease in blood flow. However, it's important to realize that blood pressure does not equal perfusion. In other words, can I have a normal blood pressure but have a patient that is in shock? In other words, can I have a normal blood pressure but potentially have perfusion issues?
Yes. You can.
Yeah, right. So if I have a cat that has an ATE, it has decreased perfusion to the back legs, and I'll have a low blood pressure in the back legs, but I'll have a normal blood pressure in the front legs, right?
Mhm.
Or I can have an animal that has normal blood pressure, but it has to have a really high heart rate and has to work really hard to maintain that. And so it's in compensated shock. So, what I'm going to say is that, just let your focus on decreased blood flow as a definition. And in particular, when there is a low blood pressure, I say, okay, your animal's now in shock when you have a low blood pressure. But again, sometimes you can't have a normal blood pressure and still have a patient in shock. But in general, low blood pressure does mean decreased global perfusion, unless you're getting a false reading or something. So again, we're going to focus on low blood flow being as the definition of shock here. In general, when you have low blood flow, you do have a low blood pressure. So we'll say low blood flow and low blood pressure are the same. But again, that is not always true. Sometimes you can have some degree of shock that's compensated and they're having to work harder to do it. They have a normal blood pressure, or you can have areas where there's normal pressure and areas where there's abnormal blood pressure. So, normal blood pressure does not necessarily always mean that they're not in shock, or low blood pressure does not always mean that they're in shock. The reason I'm going to do this is that poor perfusion fits with this lecture's classification scheme. So when we talk about shock, we're going to have to talk about shock due to hypovolemia. We're going to talk about shock due to vasoconstriction. We're going to talk about shock due to obstruction of blood flow. We're going to talk about shock due to cardiac abnormalities. And all those things will typically, have poor perfusion, and they will typically have a low blood pressure. And oftentimes the body detects that you're in shock through baroreceptors in the aorta and the carotid body, and they detect a low blood pressure. So, again, we're going to talk about, we're going to focus on, I keep mentioning this because, just kind of, it's the premise of the whole lecture. We're going to focus on shock being a decrease in blood flow. That decrease in blood flow is generally associated with a decrease in blood pressure. And the reason that we're going to do that is because that's how the body detects shock usually, is through blood pressure, even though it's not perfect. That's how the body detects a low blood pressure means there's shock. So I need to do something to fix that. And that's how we generally detect it. When we're looking for shock, we'll check a Doppler reading and we'll detect that there's a low blood pressure. And that, low blood pressure will fit with the classification scheme, or poor perfusion will fit with the classification scheme that I have here that we'll talk about further. About that later on. So what I wanted to talk about here, let me just read this one. Blood pressure, perfusion to low bodies, vein system, not aware of the cause. So what the body does, right? So the body has receptors in the aorta and in the carotid body, and those receptors, what they do is they sense the blood pressure, and if the blood pressure is low, they sense that the body is in shock, right? And that in general is a good thing, right? Because if the body senses that the blood pressure is low, Joe, what kind of compensatory mechanisms might the body do to correct that, or what things might happen to restore blood pressure?
You're saying if we have low blood pressure, what do we do to fix that?
Yeah, so the body senses that the blood pressure is low in the aorta and the carotid body.
Yeah.
And so when it senses that, the body also assumes that that means my perfusion is low. So I need to fix that. So what would it do to fix that situation?
So it's going to increase heart rate. It's going to vasoconstrict.
Mm-hmm.
What else?
Yeah. So increase heart rate, vasoconstrict, conserve water, right? So it's going to,
Rest.
and it's going to do this. We're going to talk about all these systems, but it's going to do this through the renin-angiotensin-aldosterone system. It's going to do this through the sympathetic system. It's going to do this through the vasopressin system, right? So it's going to use all these systems to, conserve water, to increase the heart rate and push out more blood, and through increasing heart rate and contractility, and vasoconstriction to, push blood up to the heart and increase preload, right? And then preserve blood to more important areas, and more vasoconstriction in less important areas, and more sometimes vasodilation in less important areas, right? And that is a good thing if you were bleeding out, or if you were in the desert and you were dehydrated. So that's why I have these, pictures here. The dog's in the desert, it's dehydrated, it's lost a lot of volume from, water losses. Well, it's going to be good for it to activate those systems as its blood pressure starts to drop. Conserve water, increase heart rate, vasoconstrict. If you have if you've been attacked and you have a big wound on you, then, again, as you're hemorrhaging, activating those systems is a good thing. And so in general, when the body senses low blood pressure, or when it senses, it assumes that that's hypovolemia, it activates those systems. But sometimes that's not a good thing, right? So sometimes you have a patient that has heart disease and it has a leaky valve. And now the blood is going in a backwards direction from the ventricle into the atria because, say, your valvular disease, right? Let's just use that as an example of heart disease, right? So it's valvular disease. Blood is going from the ventricle back into the atria. And that can lead to congestive heart failure, but it can also lead to less forward flow out of the heart, and then that causes a drop in blood pressure. Now, what does the body do in response to that drop in blood pressure? Vasoconstricts. So the blood was already having a hard time getting out the blood out of the heart because of that valvular disease, right? Now, a vasoconstrict caused more resistance, made it even harder to get it out of there. And then, was the animal hypovolemic? No, it wasn't hypovolemic, right? And so, but you've activated in response to that low blood pressure, an increase in heart rate, and you've also increased the thirst mechanisms. And so now they are in their water retention mechanisms of the kidney. And so now they conserve water and they get fluid overloaded. So you can see how, the way the body detects, hypoperfusion or shock through blood pressure is a pretty good system, but it's not good in all cases of low blood pressure. Like in heart failure, what medications do we use in heart failure when we see it?
We're going to do Lasix and then Pemobendin.
Yeah, Lasix, pimobendan, and what do those drugs do? Pimobendan vasodilates. Lasix gets rid of that extra water. Sometimes we'll use drugs like enalapril or nitroglycerin to vasodilate as well. So in heart failure, what we do with that is we tend to back these systems off that are activated in response to that low blood flow or low blood pressure, right? So, again, our concept here is that when we have poor perfusion, we have a low blood pressure, and that's what we're going to classify as shock. And we're going to talk about, things that cause low blood pressure and is often associated with hypovolemia. And that's the way, we detect shock is through low blood pressure. But, the body, when the body senses a low blood pressure and treats shock that way, it's not always perfect, and it's a pretty good system. And, from an evolutionary standpoint, when you're talking about water losses in the desert and you're not drinking, or when you're talking about hemorrhaging because you've been attacked by a tiger, but it's not a very good system, when you have heart failure. And so it's not a perfect system. And we'll talk about why, sometimes too, you can have, things going on like hyponatremia, hypovolemia, which maybe, confuse the system a bit, or make things a bit confusing as well too. But we'll talk about that more later on. What I wanted to focus on here was that, the system's pretty good. The definition is pretty good, low blood pressure, there's low perfusion. And it's pretty good for us to use it as a means of detecting shock and assuming it's there. And it's a pretty good means of the body detecting shock and assuming it's there. But it's not perfect, not just for us when we're, because there are other reasons they can't have shock, but it's also not perfect because in the body, because sometimes, that you have a low blood pressure for reasons that have nothing to do, or not helped by vasoconstriction, or not helped by volume retention, water retention. So this is a lot of the things that we just talked about here, right? So I said, what is the cardiovascular system's response to shock? So these changes are often detected by the kidneys through sodium flow, by the hypothalamus through osmolality, and the blood pressures by pressure. So in the kidneys, you have that JG apparatus, and we'll talk about that more in just a bit, but that's what detects sodium flow across there. And if sodium flow is decreased, it says, oh, I'm not getting good blood flow in there. And that's another method other than blood pressure. So we had said the blood vessels like the aorta and carotid body, those sense pressure, and they can, say blood flow is not perfect because of that. But you can also have other mechanisms, like in the hypothalamus, it can detect the osmolality of the blood. If the osmolality is high, it assumes that you don't have enough water in there. If the osmolality is low, it assumes that you have too much water in there. Or by changes in sodium flow across something called the JG apparatus in the kidney. And if there's increased sodium flow, then it assumes blood pressure or blood flow is good. And if there's decreases, flow assumes it's low. The big one I just talked about now was, the pressure mechanisms. And when these are activated, it results in the conservation of water, constriction of the vessels, and increased heart rate, which is what you just told me, right? And these changes occur via the sympathetic system, the renin-angiotensin-aldosterone system, and the vasopressin system, and also via the kidneys directly. So before we talk about these systems, though, let's talk about water balance, electrolyte balance, and see how that relates to our understanding of shock. So normally in the body, you have about 60% of it that is water, right? About 40% of that lives within the cells. About 20% of that is extracellular or outside of the cells. And of that 20%, 5% of it's in the plasma, and 50% of that is in the Jesse's coming in too. So 5% of that is in the plasma, and then about 15% of that is in the interstitial space, right? So, again, you have all this water. It's kept in separate compartments. There's not too much difficult to understand here. You just have body water that's kept in different places. But we're going to talk about how when you lose water, it can affect one space more than the other. So that's why I want you guys to have a good concept of, where the water is located. About 8 to 9% of the body weight in a dog, in most large animals, is your blood volume, or 80 to 90 mils per kg. And the blood volume in the cat is about 5 to 6% of your body weight in the cat, or 50 to 60 mils per kilogram. And about half of that is red cells, and about half of that is plasma. So just some good definitions or some good formulas to be aware of. We talked about this before. This is your shock dose in the dog. This is your shock dose in the cat. But it has nothing to do with the amount of water that they actually need. It just means if you've given them a shock dose, you've given them an actual blood volume, right? So when the body senses that, perfusion is poor, and again, it can do that through, receptors in the aorta and the carotid body that detect low blood pressure. It can do that through, sodium flow across that JG apparatus in the kidney. It can do that through osmoreceptors in the hypothalamus. But when it senses that the body is hypovolemic or not getting enough volume, or not getting enough pressure, it will perfusion. It will activate the sympathetic system. It'll activate the renin-angiotensin-aldosterone system, and it'll activate the vasopressin system. So the sympathetic system, again, primarily starts with activation of these receptors in the aorta and the carotid body that are baroreceptors, and they detect a drop in blood pressure. And assuming and they assume that, while it's not always true, like we just talked about, they assume that drop in blood pressure is due to a drop in perfusion. And so it tries to thereby improve perfusion. And usually that perfusion has to do with hemorrhage or dehydration. And so what it'll do is it'll activate an area of the brain, or the medulla, that then goes down to the spinal cord, and then sends signals via the nervous system out to different areas of the body. And so it'll cause vasoconstriction within the kidneys, or within the vasculature all throughout the body. And it'll vasoconstrict more in areas that are less important, like the skin, and vasodilate in areas that are more important, like the heart, brain, and lungs. It'll cause catecholamine release from the adrenal glands via the nervous system. It'll cause the kidneys to activate the renin-angiotensin-aldosterone system, and we'll talk about that system in a little bit, but that also can cause vasoconstriction, and that also can cause water retention. It'll activate on the heart to increase cardiac contractility and the heart rate, right? And then as the adrenals release catecholamines, they can also act on the heart. Those catecholamines can act on the vessels to vasoconstrict. And then it'll also act on the hypothalamus to release vasopressin, the sympathetic system, and vasopressin can then act on the kidneys to conserve water and can also cause vasoconstriction. So you can see how, the sympathetic system can not only directly do things to improve perfusion through water conservation, through vasoconstriction, through increased cardiac contractility and heart rate, but it can activate other systems like the renin-angiotensin-aldosterone system and the vasopressin system to also cause things like vasoconstriction and conservation of water. Aldosterone release is another one that does through the renin-angiotensin-aldosterone system. The renin-angiotensin-aldosterone system, and again, I don't need you to memorize this. This is something I had to memorize for boards and stuff like that. But I do need you to know about it because you'll use drugs like enalapril that are angiotensin converting enzyme inhibitor, right? Or this ACE inhibitors, right? And so I'll need you to know how those drugs work and what molecules they work on and how that causes vasodilation. And it's going to do it by inhibiting, this enzyme here, which is going to prevent angiotensin 2 from being formed, right? So again, if the body through decreased blood pressure in the aortic and carotid body, or through sympathetic stimulation, or through decreased renal flow across the in sodium chloride across that JG apparatus, or decreased renal afferent arterial pressure, if it senses those things, it will release renin. Renin then causes the conversion of angiotensin to angiotensin 1. And then angiotensin 1 is converted by angiotensin converting enzyme to angiotensin 2. And then angiotensin 2 can do lots of good things. It can cause vasoconstriction. It can enhance sympathetic activity. It can lead to aldosterone release, which just causes salt and water retention. It can also cause vasopressin release, which can cause thirst and further vasoconstriction. So all these systems one can activate the other. The sympathetic system here is activating the angiotensin system. The angiotensin system is helping the sympathetic system to be activated, and also activating vasopressin. And then vasopressin is released by angiotensin 2 in the sympathetic system, also by increased osmolality. If the body assumes if the osmolality is up, then there must be some volume depletion, and that's why I have more osmoles. And so that's a vasopressin stimulant that can then cause vasoconstriction and can cause renal fluid reabsorption and increased blood volume that way. You also have mechanisms for fluid overload, like ANP and nitric oxide. So we not only have mechanisms that detect when there's too little fluid, and that we think that there's decreased perfusion because of that, but you also have mechanisms that detect when there's too much fluid. And so, what is the test that we do sometimes in cats to look for heart failure?
Are you thinking like a cardiac probe BNP or?
Yeah, pro-BNP, right? So
Yeah.
ANP is atrial natriuretic peptide, BNP is brain natriuretic peptide. They all have to do with volume overload. Sometimes they're released from the brain, or sometimes they're released from the atria. But when the body detects that there's overload in the atria here, it releases ANP. It can also release BNP from different areas, but it releases this ANP in response to that stretch of the atria. And that causes stimulation of sodium and water loss from the kidneys. It inhibits angiotensin and vasopressin. It causes suppression of thirst, and it dilates the blood vessels, right? So it does the opposite of the systems I just talked about. So it's a counter-regulatory system. And one of the reasons we can measure it in heart failure patients is because they tend to be overloaded, right? So they don't tend to be underloaded. They tend to be overloaded because they're inappropriately, like we just talked about in the beginning, they're inappropriately activating these systems, even though they never really had a low blood volume. And that's just a drawback of the system. The system is designed to respond to, dehydration and hypovolemia as a cause of low blood pressure, not so much a poor heart function as a cause of low blood pressure. Nitric oxide is another thing that causes dilation of vessels. It's very complicated, so I just kind of showed that in here that it is released locally within the tissues to maintain blood flow and cause vasodilation. So again, I talked a lot about blood pressure and how blood pressure correlates with hypovolemia in general, although not always. And heart failure was an example of when it doesn't, indicate that. But, typically the body, when it senses a low blood pressure, it senses hypovolemia that way, and then it does things to correct it. Some temporary measures like vasoconstriction to maintain preload. And more importantly, it constricts to the less important tissues and vasodilates or maintains blood flow in the more important areas. It also causes conservation of water so that you eventually don't have to vasoconstrict and all the tissues can get blood flow. But there are other mechanisms that we also touched on that are important in sensing when blood flow is low, like the kidney, the JJ apparatus, and then these osmoreceptors in the hypothalamus. And so if you have increased osmolality, that generally indicates fluid loss, and that causes vasopressin release. And you have decreased osmolality, so if I just drank a bunch of water and I diluted out all my electrolytes, that usually indicates fluid gain, and I have decreased vasopressin release. Now, what about, I always thought, when I was studying to school, like, what if you had, hypovolemia, I got myself real dehydrated, but then I drank a bunch of water, but not enough to restore my hypovolemia. So I'm hypovolemic and hyponatremic, or I'm bleeding. Say I'm bleeding, I'm losing, a bunch of electrolytes, and I'm drinking water, restoring my volume that way, but I'm not replacing it with any electrolytes. So now I'm hypovolemic and hyponatremic. Would I release vasopressin or not? And the volume is going to win. Vasopressin will be released due to the hypovolemia or due to decreased blood pressure, or I should say the hypotension more than hypovolemia. But if you are hypotensive, even if you're hyponatremic, your body will say, hey, you need to add water to the system, and it'll increase your thirst, and it'll cause vasoconstriction and increase heart rate and all those good things. Volume or low blood pressure again has a greater effect. Sometimes fluid loss can be weird too. So sometimes it can be greater in one compartment than the other. And that's an important thing to somewhat recognize when we're thinking of decreased perfusion and we're thinking of hypovolemia and hypotension. So hemorrhage is mainly going to cause vascular losses. I'm going to show an example of this in a second. Diabetes is mainly going to cause intracellular losses. And that's because, it depends on whether you have an isotonic versus a pure water loss as to where you tend to see most of your losses at, right? So if we think about pure water loss, right? So this is say this top area up here, I don't know if you guys can see my little cursor, but this top area here is the interstitial department, and I'm sorry, intracellular department, and this bottom area is the extracellular compartment, right? And if I lose just pure water, pure water, what that does is as I lose that water, look at the osmolality in the bottom department, the extracellular compartment. It's gone up, right? Because I have less volume in there. I have the same amount of electrolytes, but with less volume. So what it's going to do, it's going to pull water from the interstitial or from the intracellular into the extracellular. And now your water loss is going to be equal in both compartments. So that's how pure water loss can cause equal loss in both compartments. If you have a patient that has isotonic losses, so like you do with vomiting and diarrhea and stuff like that, what they'll do is they'll lose water, but they'll lose electrolytes. And now there's not that stimulus to pull water from inside the cells to the extracellular compartment, from the intracellular to extracellular. So the losses tend to be greater when you lose isotonic losses. The losses tend to be greater in the compartment where they're lost from, which, like with vomiting, is going to be the extracellular compartment. It's going to all go into the GI tract, and then it's going to get lost out of the GI tract. And usually those are pretty isotonic fluid losses. Not completely isotonic, but they do have some electrolytes in them. So, when you see like things like vomiting, it tends to cause more isotonic losses, and it causes losses in both departments. When you have just dehydration and you're losing a lot of fluid in the kidneys, it tends to be a lot of pure water loss, and you tend to lose it in all spaces. With hemorrhage, you mainly lose it from the vascular space, and it loses electrolytes with it, so it tends to mainly come from the vascular space. Diabetes is weird in that you get a lot of increased glucose in the blood, and it pulls that sugar pulls that blood out of the intracellular space into the intravascular space and the interstitial space, and that's where most of your water then is lost from because of that high glucose. It tends to mainly be intracellular. So again, depending on the disease that you have, if you have hemorrhage, you're mainly going to have vascular loss. With diabetes, because of the high glucose pulling that water out of the cells and then out to the kidneys, it's mainly going to be intracellular loss. If you have vomiting with pure water, it will be more loss or with dehydration with pure water loss, will be loss in both spaces equally. And with isotonic fluid losses, where there's some electrolyte losses, you won't have that osmotic pull, so it'll mainly be in the extracellular space, and that's what that was showing here. But important here just to understand that the fluid losses can vary in the department depending on what the cause of the hypovolemia is. And it's not always the same in all departments. And that's why sometimes you'll have these cats with diabetes that come in very, very volume depleted or very, very dehydrated, but they don't have a lot of hypotension or volume loss because they are mainly losing it from the intracellular space. Versus if you have a dog that comes in with the same amount of water loss from hemorrhage, it will be, very, very hypotensive because of that. That all make sense?
So far, so good.
So one of these things that we are taught was, if you're 0 to 5% loss of body water, you can't detect it. 6 to 7%, you'll start to see a skin tint. You might see some mucous membranes that are dry. At 8 to 11%, you'll definitely see a skin tint, dry mucous membranes, and you might start to see signs of volume depletion. And I say volume depletion, like increased heart rate, increased vasoconstriction, right? So dehydration can be from the interstitial space, right? Or it can be from the vascular space. You're not going to see signs of, volume depletion until it starts to happen from the intravascular space, right? So, up to about 7%, you typically tend to see, most of your water, if your animal is vomiting or, not drinking or whatever, up to about 0 to 5%, maybe up to 6 to 7%, you're typically going to mainly see interstitial losses, and you're not going to see too much in the way of vascular losses or hypovolemia at that point. But then once you start to get above 8%, and especially as you go to 12 to 50%, then you're going to see more definitive signs of volume depletion, increased heart rate, vasoconstriction, potentially hypotension, as it gets greater and greater and greater, decreased urinary output, decreased mentation, and as you get to 15%, you're going to be pretty much dead at that point. So again, up to 7%, mainly interstitial losses, greater than 8%, mainly hypovolemia. However, what did I just tell you? I went over this and I said, well, it's not always the same. So these numbers are great, and we learned this in school, right? But again, it does depend on the type of water that you're losing as to when you're going to see more vascular losses or when you're going to see more interstitial losses or intracellular losses. And so a diabetic animal could have a pretty good amount of total body water loss and really show no signs of hypovolemia because they mainly lost it from the intracellular space. And a vomiting dog, may start to show it a lot faster. And for sure, a dog with hemorrhage may start to show it a lot faster because they have mainly these isotonic losses. So I find that these formulas work good and well for like your vomiting dogs is probably the best thing that they're used for, but they're not 100% accurate. But if you start seeing signs, the important thing I think that this diagram shows you is that if you start seeing signs of volume depletion, in other words, if you don't see just a skin tint, you don't just see dry mucous membranes, but you start to see my heart rate's up. The blood pressure starting to come down, and are their heart rate's up and they're compensating, right? Well, then I'm going to start to assume that they're probably more in this 8% dehydration deficit. And once I start to see that, what is the big difference in how we give them fluids that we talked about before? If they're hypovolemic, versus if they're just if they're dehydrated and hypovolemic, so they have volume losses within the intravascular space, versus if they're dehydrated but they don't really have a lot of vascular volume loss, it's more interstitial losses. How do I treat those differently?
If we're seeing signs of um, intervascular loss, then we'd be thinking more along the lines of doing some shock boluses
Yes.
versus just doing like twice maintenance for
Versus if we
interstitial
think
loss.
that then we're thinking maintenance, replacement, ongoing losses, if they just have, say 0 to 5, maybe even 6 to 7. But if they start having signs of 8 to 11 and hypovolemia, then I'm gonna start giving them a shock dose, a quarter of a shock dose, half a shock dose, whatever I think is appropriate. And then I'll start rehydrating them after that, right? So, again, dehydration is common in patients, and it can happen in the intravascular space. It can happen in the interstitial space. It can happen in the intracellular spaces. And the type of water loss that you have will determine in which space it happens more. And we can use this diagram to determine how much body water they lost, and it's sometimes helpful. But how we treat it is going to differ depend on where they're losing it. And if they're losing it more in the vascular space, we're taking more of a immediate correction with a shock dose to right into the vascular space. But if it's more in the interstitial space or intracellular space, then we're thinking of more slow replacement, because it has to go into the vasculature and then slowly make its way into the interstitial space and then make its way into the intracellular space. I didn't talk about that this much, and I'm not going to touch on it here, but when we think of intracellular losses, typically the way we recognize that is through things like hypernatremia. In other words, if they're hypernatremic, they're going to be pulling fluid from the space where they're hypernatremic, the intravascular space, from the intracellular space into that intravascular space or interstitial space. So typically when we are worried about intracellular losses is when we see our hypernatremic patient, because we know that that patient is pulling water out of their intracellular spaces into that hypernatremic interstitial compartment.
So does this change your plan for like a diabetic cat that's not showing signs that it's too dehydrated? Does that change your fluid plan?
No, I mean, diabetic cats, you got to look at, I'm going to replace their fluids based on what I think their total body water loss is. So, I might try and estimate where I think they're at and then give them that as a replacement need plus their maintenance plus their ongoing losses, right? And if I think that, and again, they usually, because of all that glucose pulling water out of into the vascular space, they usually don't have a lot of volume or vascular hypovolemia, or they have more just dehydration in the intracellular and interstitial spaces more than the vascular space. So, sometimes I'll say hypovolemia. When I say hypovolemia, I'm referring specifically to loss in the intravascular space, meaning that a high a dehydrated patient can be Isaiah's calm. A dehydrated patient can be hypovolemic, um, and a dehydrated patient can be normovolemic, right? So, a hypovolemic patient is hypo. Let me put it this way; it's kind of confusing. A hypovolemic patient is always going to be dehydrated, right? It's going to have water loss that's causing the hypovolemia, and it may not have a lot of interstitial losses, but it has a significant amount of water loss from the vascular compartment. But a dehydrated patient does not have to be hypovolemic. In other words, a dehydrated patient could have plenty of volume in the vascular space, but not enough in the intracellular or interstitial space. So, and again, your diabetic patient may be dehydrated, but doesn't have a lot of vascular losses, so it's not hypovolemic. So in that patient, I'm maybe not going to be bolusing, but I'm just going to be, thinking of replacement, maintenance, and ongoing losses. The type of fluid I use might vary, depend on, their electrolyte losses. And if they, I think they have a lot of sodium and chloride loss, then I might use a 0.9% sodium chloride solution. If they have if I need if they're very acidic and I need a buffer, then I might use an LRS solution. So it'll vary depending on mostly the fluid type I use. Mostly with my diabetics, I'm thinking maintenance, replacement, ongoing losses. And the fluid type I use basically depends on what their electrolyte status is like most of the time. Does that make sense?
Yeah, that does. Thanks.
I'll tell you, it's not an easy subject to teach. There's lots of different, ways.
Yeah.
And when I study this subject, I often like have to go over it again and again and again because there's just so many variables how one thing can affect another. I'm gonna simplify, my shock treatment in a second, but this part here, there's a lot of information here, and it can get a little confusing and sometimes hard to understand. Okay, so this is a lot of criticalists love this little diagram here, and it has to do with, how we maintain blood flow through preload, contractility, afterload, resistance, things like that. And how you essentially maintain the thing we talked about in the beginning, the cardiac output to maintain perfusion. I don't really like this diagram too much here, and I tend to use look at it a different way. But again, this can be very helpful, and sometimes you'll look at it in the terms of cardiac output and how that's affected by stroke volume and heart rate. Stroke volume is affected by preload, contractility, and afterload. Preload is affected by venous return, which is then affected by your cardiac output, and then how all these other centers like the control the sympathetic system, renin-angiotensin-aldosterone system, vasopressin system, how they have an effect on all these different factors here, like preload, contractility, and afterload.
I really like that slide that you just said, that tree of life one,
Yeah.
because I always talk about how, you know, um cardiac output, the equation is stroke volume times heart rate, right?
Mm-hmm.
So heart rate is 50% of just that one little bit. So we start, we start losing volume. That's why the heart rate is one of that first thing to start helping with that equation. It starts like
Yep.
compensating for it. So I really like that one that you have right there.
Yeah. No, it's very popular. You'll see it in all the physiology books. And I don't dislike it, but I think I have a better way of showing it. And I'm gonna show you now. So the blood flow, one of the equations that's important, is equal to the change in pressure divided by resistance, right? And so if you just look at this equation, you're like, what the hell? What does that even mean, right? And it's real easy to show you, what it means, right? So let's just imagine a simple garden hose, right? And so the change in pressure is equal to the pressure in and minus the pressure out, right? So the pressure in this garden hose, I want to make water flow through this garden hose, right? So the pressure in is my faucet. I have to turn that valve and increase the pressure, going into the entrance to that garden hose, right? And then if I have a bunch of pressure out on the other side, so right here I'm showing you how I have the spigot turned off, right? I have the little what's the little nozzle I'm using, right? I don't have it opened up. So now there's a lot of high pressure at the end of this hose. The pressure going and the in here is say 50, and the pressure here at the where I have this thing turned off is 50. But if I open up now, I've dropped the pressure here to equal to the atmospheric environment, and the water shoots out, right? So you have to have a high pressure in, you have to have a low pressure out, and that's how you get water to flow through that hose. And it's again a very common, simple concept. But when you see it in the equation, sometimes that change in pressure, like what do they mean by the change in pressure and how does that affect flow? It's all just saying I have a pressure in, which is the left side of the heart, and I have a pressure out, which is the right side of the heart. We know pressures on the left side of the heart are about 120 maximally, and pressures on the right side of the heart in the right atrium are as low as 0. So that's why blood flows from the left to the right side. Now, and in the ventricle, you say, well, if the pressure is always high on the left side, how does blood ever get into the ventricle? Well, it goes from 0 to 120, 0 to 120, it goes up and down, right? And diastole, it gets real low, and systole, it gets real high. And it fills up when it's real low and goes from one side to the other, and then it pushes it out when it's real high. The other part of this equation is the radius, and it's the radius to the fourth, right? So or I'm sorry, it's the resistance, right? So we said change in pressure divided by resistance, right? So the change in pressure, we want the pressure in to be high, we want the pressure out to be low. We also, to maximize blood flow, we don't want a lot of resistance. We'll talk about, we need some resistance, we'll talk about why in a second, but we don't want a lot of it, right? And so the resistance is equal to a constant, which is just a set number, times the viscosity times the length. We really can't change the length of the blood vessels. We really can't change the viscosity of the blood. But the radius is something that the body often changes to improve blood flow. And so you don't want the blood vessels to be too constricted, and you don't want them to be dilated. And a small change in radius can have a big effect on the resistance, because it's radius to the fourth, right? So a small change in the radius can have a big effect on the resistance. So just, constricting the vessels can really limit the blood flow that goes through there. Another way, okay, so when you look at this equation here, right, change in pressure divided by resistance, right, and we understand how this equation works, and as far as maintaining blood flow, we want a high pressure in, we want a low pressure out, we don't want a lot of resistance, right? And so what about, if we apply that to the body, or how does that equation work with the heart? And we could say that the left ventricular pressure is the in pressure, and the right atrial pressure is the out pressure divided by resistance. And so that's how we get blood flow. And like I talked about just a second ago, the left ventricular pressures, they can go from 0 to 140, right? And the right atrial pressures are 0 to 8. So that's why blood's going from the left ventricle out to the, back to the right atrium. But it can get back into that ventricle, because at some point that pressure is going to drop and be lower than the left atrial pressure, and it's going to go back in there. But it gets low and then high, low and then high. And then when it's low, that's when it fills up. And when it's high, that's when it pushes out. And that's, again, all this diagram is showing here. You have a high pressure left side, you have a low pressure on the right side. The blood goes from the left side where the high pressures are over to the right side. Eventually the pressures do have to decrease here to be able to push it out there. The arterial side always, the arterial venous system, or the arterial vascular system always has a high pressure in it to push it out. And it's important that, even though you look at here, it's if you look at the amount of blood in the arterial side versus the amount of blood in the venous side has a much higher capacitance. It can handle a lot more blood than the arterial side. A lot of times when people, one of the things that we would do, like back in my residency days, is if you're worried about an animal becoming overloaded, you would check the arterial pressure to say, oh, its pressure's high, it must be overloaded. And a mentor of mine would say, well, that's a late indicator. The venous side, is going to take up all that extra fluid to prevent the arterial side pressure from going way up. So if your arterial side pressure is going up, your venous side is extremely overloaded. You're probably going to develop things like, congestive heart failure and ascites and pulmonary edema, things like that, way before your arterial pressure goes up, because your venous side will start to accumulate all that fluid, and that won't increase your arterial blood pressure. If you check the CVP, it would increase your CVP, or central venous pressure, but it wouldn't increase your arterial pressure. But this diagram again here is showing how blood goes from the left side over to the right side, how the venous system has a much higher capacitance to hold on to water, and the arterial side has a much smaller amount. And it's important that the arterial side constricts, right? It has to maintain a balance. I should have another diagram that shows that later on, but it has to maintain a balance where it constricts some here to maintain a pressure in the arterial system, but not so much that it increases resistance too much. So this is again going back to your tissue blood flow, your arterial pressure, or your afterload, how much you constrict that side to maintain that pressure, and your venous pressure afterload, resistance afterload. So it's showing how preload, contractility, stroke volume, heart rate, like Jesse was saying, stroke volume, heart rate, improve your cardiac output, and that's going to improve your arterial pressure, right? And so these things are all important, right? And if I want to increase these things, then, all important to improving tissue blood flow. If I increase arterial pressure or afterload, that's going to increase this number here. And if these numbers stay the same, then I want to increase tissue blood flow, right? If I increase the pressure in, keep the pressure out low, keep the resistance not too bad. I'll increase test tube blood flow, and I can do that by increasing this pressure in through these little factors here, right? So how do I do that? Well, I do that through sympathetic stimulation. I'll increase contractility, I'll increase stroke volume, I'll increase heart rate. That'll increase cardiac output, that'll increase afterload. But be careful, because it'll also cause vasoconstriction, which will increase arterial pressure, but it'll also increase the resistance in the arterial system. And it, may help increase. So it has like different things it does. It helps preload that vasoconstriction. It helps increase arterial pressure, but it increases resistance. That's going to have a negative effect on it. So it's not, always a, in that way, it may somehow decrease cardiac output. It has ways that can increase and decrease cardiac output. So when you think of these systems and how they, work, some sympathetic stimulation is good, but at some point in time, it actually becomes harmful if it has a greater effect on the resistance. I don't know, just kind of neat to see it like that. So again, preload here, contractility, stroke volume. If we look at it not from the terms of left afterload or atrial pressures, but if we look at the average of left ventricular pressure, right? They all increase left ventricular pressure. Sympathetic stimulation will increase contractility, will increase heart rate, stroke volume. That'll increase your left ventricular pressure. But if you have a lot of vasoconstriction, you're going to increase that afterload, and that may actually decrease your tissue blood flow. So you got to have that balance. You can't have, too little sympathetic stimulation, but you can't have too much of it either, especially if you have too much of it working on the blood vessels. This is showing the same here. Here, if you're looking at blood flow, if we were super vasoconstricted and overloaded in the heart, we wouldn't get much blood flow. If we were super vasodilated and didn't get much preload to the heart, we wouldn't get much blood flow. You got to have that right, nice middle ground right here, right? Where you have, enough blood flow in the vessels to, let the blood flow through it, and then enough to get enough blood back to the heart to maintain preload and keep that system circulating at its optimum. You don't want too much vasoconstriction. You don't want too little vasoconstriction. You don't want too much preload. You don't want too little preload. You want that perfect number right in the middle there. And the only reason I point this out is because sometimes you always think, oh, preload is always a good thing. Vasoconstriction is always a good thing. It's not. You got to have that right balance. I can't give too much norepinephrine, or it might actually cause harm to that patient. I might get myself in this situation here. So, just we're going to go talk a little bit about shock right here now, but just in conclusion, blood pressure is monitored by the body, now blood flow. And that's not always a good thing. Sometimes, you can have situations where blood pressure does not equal blood flow. You must have a balance of all the factors, and changing one will often affect the other. So, don't think like one thing is always a good thing. Oh, increasing sympathetic system is going to increase preload. That's going to be great. No, it actually may increase resistance too. So you got to consider all the things that it does. So a lot of times when you guys see shock, they'll classify it as, well, what kind of shocks have you seen classified, or what are you, like if I say, name me a type of shock, what type of shock would you say?
Hypoglycemic.
What was that one, Jesse?
Sorry, I am at a brewery. Hypoglycemic.
Hypoglycemic. So
Yeah, and when I think of shock, I jump right to hypovolemic.
Hypovolemic. Okay, so hypovolemic, right? Or you could say, I had a couple of beers before I started this talk too. I was like, man, I feel a little. Actually,
I'm the only one. I need to catch up.
Actually, I only had one beer, but it was this one my father-in-law gave me. I had like 7.5. I was like, damn, that thing hit me a little bit. But yeah, so we, you have anaphylactic shock, you have septic shock, you have hemorrhagic shock, you have, sometimes they'll call it distributive shock, you have hypovolemic shock, right? So some of the ones that you just said, right? Those are all types of shock. They're all good definitions of shock, but I'm gonna say, let's just break it down into 4 categories. And all those types of shocks that I just mentioned will fit into one or all of these categories, right? So you have hypo, and this is part will be a little bit more straightforward, hopefully a little bit better to understand. Because I know the first part, even though I'm talking about, sometimes I get a little confused as to how to explain this best. I know it in my head, but sometimes I get a little difficult the concept I want to relate to you guys. But this part's more straightforward. So I'm going to break it down into hypovolemic, vasodilatory, cardiogenic, and obstructive. So, and let's talk a little bit about what each one of those are. So with hypovolemic shock, it's pretty straightforward, right? The problem is you have a decreased volume. And it's what we call an absolute decreased volume. There's a definite, half the blood volume is in that animal, right? Or, you don't start to see it till about, 30% blood loss. But, you've lost 20 to 30% of your blood volume. They're now hypovolemic. Common causes of it, hemorrhage, dehydration. As a result of that, all those systems that we just talked about are activated, right? The renin angiotensin aldosterone system, the vasopressin system, the sympathetic system. They're going to increase heart rate. They're going to increase contractility. They're going to cause vasoconstriction. That's going to work on that tree of life like we just talked about to restore preload, hopefully not cause too much vasoconstriction. And, in general, they tend to be a good thing or a bad thing. What would you guys say? In general, by activating the system, is that good or bad?
Sorry, my cat was on the banister, like ready to jump off, so I was distracted. What was the question?
It's a good thing, right? So if I have hypovolemic shock and I have decreased volume, and it's because of hemorrhage, dehydration, I've activated all these systems, and then they cause vasoconstriction and they cause water retention and they cause increased heart rate. They're trying to restore blood flow to the body because that is low because of that hypovolemia, and usually have a low blood pressure too, although you could be compensated. And that is a good thing. They're, especially if they're, compensating, that they're doing their job. They're maintaining, they're having to work harder to maintain that blood flow and maintain that blood pressure, but they're doing it. And how am I going to treat that form of shock if I suspect it?
With replenishing the fluid loss.
The fluids, right? So, and some of these questions I want to ask that are just, straightforward, but it just shows me that you guys are, understanding, right? So if I have, hypovolemic shock and I have decreased volume, what I do, I give them fluids. Sometimes I need to give them blood, right? Now, vasodilatory shock. So that is when the vessels are very dilated, and because of that vasodilation, that's causing this system that I showed here, right? There's no preload back to the heart. Now blood flow, this is a severe form of it, right? There's basically zero blood flow here, right? But, if you decrease that preload, now you've caused a situation where, you're not getting enough blood flow, to the heart or, to maintain a blood pressure because you're weak preload. And you also don't have a lot of tone in the vessels. So it's a bigger compartment and, all the blood just kind of pools in the vessels now, right? And common things that can cause vasodilatory shock are things like acepromazine. I think acepromazine is a good example of just pure vasodilatory shock, right? Acepromazine can be a alpha blocker. And then because it blocks those alpha receptors, it can cause vasodilatory shock. And then, our patient's blood pressure drops, right? And perfusion drops. And so in response to that, what does the body do? It activates those same systems. Renin angiotensin aldosterone system, sympathetic system, vasopressin system. But this time, they're just not working. They don't do their job, right? They just do not work. In hypovolemic shock, it does its job. They do the things they're supposed to do. But because those alpha receptors are now blocked, at least the vasoconstriction part, it can't vasoconstrict because they're blocked, right? So what do I do to treat that? If I have a drug that I've given that I think is causing it and I can reverse it, I'd reverse it. If sometimes they'll refer to this as a relative hypovolemia. In other words, if they're just slightly vasodilated, especially on the venous side, I'll just put a little more fluid in there and that will restore the preload that way. But if they're extremely vasodilated, then I need to give a vasopressor. I need to give something that'll constrict those vessels. So what is the most common thing that I use these days to constrict those vessels?
Norepi.
Norepi. So we used to be afraid of norepi. We used to use a lot of dopamine, and dopamine is like, depends on the dose that you use as to whether you get vasoconstriction, or you get more alpha activity or beta activity. So at low doses, dopamine like 0 to 3 micrograms per kilogram per minute actually causes vasodilation via dopamine receptors. At 5 to 10, it starts to cause more beta effects, so increased heart rate. And after 10, it tends to cause more alpha effects and vasoconstriction. What we found is that dopamine just wasn't working. And they used to think it caused less arrhythmias, but there was some stuff in humans that showed it caused more arrhythmias. So then we started, using more norepinephrine, and some people use epinephrine. We use more norepinephrine, which has, mainly alpha effects, some beta effects, but not as much as as the alpha effects that it has. So it tends to cause a lot more vasoconstriction than
What about
increase.
dobutamine?
So
I was just going
dobutamine,
to ask that.
yeah, that's mainly beta. It mainly has beta effects. So dobutamine we use when we want to increase heart rate, like in a situation where a drug has decreased cardiac contractility. But usually we'll work on the vasodilatation. Usually you'll give norepinephrine. It'll give you some beta effects. But if you don't think you're getting enough beta effect from the norepinephrine, then you might add dobutamine, especially if you look at the heart and you see it's not contracting very well. So, again, just to go back and review, vasodilatory shock, a common cause, I would say, of just pure vasodilatory shock. I'm going to talk about things that can cause vasodilatory and hypovaginic and cardiogenic, right? But something that could cause just pure vasodilatory shock, I would say acepromazine is a good example of that through alpha blockade. And if you just have some, minor vasodilation and relative hypovolemia, you might just give some fluids. But if it's really bad and you can't reverse the blood, then you might have to give something that, can try to really kind of overcome the effect that drug has on those receptors. And the most common drug we use these days is norepinephrine for an alpha effect, a vasopressor effect, for a constricting effect, right? We used to use dobutamine or dopamine. You can sometimes use other drugs like phenylephrine, which is pure alpha. You can sometimes use drugs like epinephrine. We use that more in a CPR setting, but some people will give epinephrine CRIs. But anything that has an alpha effect. So dopamine kind of gone out of favor. Norepinephrine is the new in favor, but you could use epinephrine. You could use phenylephrine. Going back to the drug you guys asked about, dobutamine, that's more of a beta effect. That's for more, improving heart contractility, and that's what we're going to talk about next. So cardiogenic shock is when you have a decreased blood flow, and usually indicated by decreased blood pressure due to a problem with the heart. The one that I would say is the one that's treatable, the one that we would try and fix or give a drug to correct it, would be poor contractility, right? So, but cardiogenic shock's not always due to poor contractility, right? Sometimes it's due to a leaky valve. Sometimes it's due to a cat that has hypertrophic cardiomyopathy and has a very thick ventricle. So it's not always due to poor contractility. And so, I'm going to talk real quickly about how to treat it when it's due to poor contractility. But if it's due to other causes, you're not necessarily going to treat it the same way. So say you had poor contractility due to a dilated cardiomyopathy or medication that you gave. Same situation. Your pressure is going to drop, your blood flow is going to drop, you're going to activate all these systems, and they're going to try and help it, but they again can't. And so if they can't, then I would use something that is a positive inotrope or has a lot of beta effects on it. And so you could use norepinephrine, you could use dopamine, but one that has just pure straight beta effects is dobutamine. Usually, if I have vasodilatory shock or if I have cardiogenic shock, I usually have both of them. I don't usually have cardiogenic shock without, vasodilatory when I have things like sepsis or stuff like that, right? But it's not very common to have a patient that was given a drug that only affects the heart but not the vessels, or a drug have a situation like sepsis that only affects the heart and not the vessel. So usually I'm going to give norepinephrine. If that's not working, then I'm going to add my dobutamine on top of it. But if you had just straight up cardiogenic shock, poor contractility, then yes, you might use something like dobutamine. Now, I say here, those systems are sometimes good but not working, but they're sometimes bad, right? And so if you had cardiogenic shock or poor forward flow, not because of a contractility issue, because of a leaky vessel or a leaky valve, or because a cat has HCM and it has a very thick ventricle that blood can't get into, well, then in that situation, you activate these systems, and what do? They cause harm. They cause further resistance. They cause further overload to the heart, right? They're not doing good things. They're actually a bad thing. So in that situation, I'm actually going to back off those systems. That's a whole different topic. We're not really talking about, congestive heart failure and heart disease. We're talking about things that more affect contractility. But just keep in mind that you can have cardiogenic shock that activates these systems via the same mechanisms: poor blood flow, poor blood pressure. And you actually have to not augment those systems in that situation because they're not working, but you actually have to reverse those systems because they're working too much. And so it depends on what, cause of your heart disease is. In this situation, the one we're going to focus on is poor contractility due to a drug or due to inflammatory mediators or something like that. Right? That makes sense?
Makes sense.
Yeah. And then obstructive shock is we have an obstruction to flow, right? So like a GDV is compressing the cava, and now blood can't get back to the heart. Or you have pericardial effusion, where you have a big amount of blood within the pericardium that's squeezing the heart, and blood can't get into the heart. So that would be considered obstructive shock, right? So again, in that you're gonna activate those systems. They're going to be not very effective. What you need to do is you need to relieve the obstruction. So again, hypovolemic shock, give fluids. Vasodilatory shock, fluids plus or minus vasopressors. Cardiogenic shock, positive inotropes. But sometimes, due to other causes, we actually tend to back off these systems. And obstructive shock, you're going to relieve the cause of obstruction. You may give some fluids and stuff with it as well too. So what about all these? Jesse's trying to come back in. What about all these other types of shock? We had distributive, septic, neurogenic, anaphylactic, traumatic, hemorrhage. So you can fit those into one or all of these categories, right? So I think the perfect example I like to use is a patient that is on anesthetic drugs, right? So that patient that is been given anesthesia and is on drugs and becomes hypotensive, it could have all three forms of shock, all three forms of these shock, or not all four, but three of these. It could have some hypovolemic, it could be vasodilatory, and it could be cardiogenic, right? So how is that possible, right? So what do I mean by that? So if I have a patient and I'm going to have them go under anesthesia to remove a foreign body, or even if I'm going to do a spay or neuter and I fast them the night before I put them on anesthesia, would that make them a little hypovolemic potentially? I mean, fasting is probably not going to make you too hypovolemic. But say the owner got a little aggressive and stopped food, like, food and water 24 hours before you anesthetize it. Yes, it potentially could make it hypovolemic, right? For sure, if you had a dog under anesthesia that had some intestinal foreign body and had been vomiting prior to anesthesia, that dog definitely can be hypovolemic. So your anesthetic patient, especially if they have significant underlying disease, could have some degree of hypovolemia. If you gave them drugs, could those drugs cause vasodilation? Yes, all the drugs, opioids, acepromazine, your phenothiazines, even your benzodiazines, although they're not big ones, could potentially cause some vasodilation. And could those drugs decrease cardiac contractility, especially your gas anesthetics? Those 100% can cause vasodilation and poor cardiac contractility, right? So the medications that we gave this patient, potentially could cause vasodilatory and cardiogenic shock. So I would say, a patient that's been given, anesthetic drugs can have all three. Anaphylaxis can also cause Hy3. You have leaky vessels from the inflammatory meters. You have vasodilation from the inflammatory meters. You have cardiogenic shock from the inflammatory meters. Sepsis. The inflammatory meters, again, same thing, can cause all three forms of shock. They can become hypovolemic through leaky vessels, vasodilatory through how it interferes with nitric oxide, and cardiogenic, how it affects the heart. And sometimes if they have blood clots forming in the vessels from DSC, they can have some obstructive shock as well too. So you can see how different types of shock that we talk about usually fit into one or more of these categories. Sometimes you'll hear the term distributed shock. That's mainly they're talking about vasodilatory shock, but that's not always the case. And again, septic shock is usually, we think of vasodilatory shock, but it could have a combination of hypovolemic and cardiogenic as well too. Now, what if I have a patient that has all three of these? All I know is that the blood pressure is low and the perfusion is low. How do I know which one of these it is that's causing the blood pressure to low and cause the perfusion to be low?
I guess if you're giving fluids and replenishing volume and it's not responding, then you can rule out just hypovolemia.
So, yep, that's one way we can do it. We can just give them a trial fluid bolus and see what happens. And that's not a bad way to do it, right? Because a lot of times, if they're vasodilated, they have what's called a relative hypovolemia. So fluids is not going to hurt with the vasodilated patient. If I had a heart failure patient, for sure I wouldn't want to do that. But if I just have poor contractility, I think due to sepsis and stuff like that, and I know they have a hypovolemic component, or if I have a patient that's under anesthesia, and I think that the drugs might be causing a decreased cardiac contractility, I might, turn my gas off or turn it down. But I also might give them a little fluid bolus because, again, it's not like they're overloaded like you would have with heart failure. This is a patient that, I think is cardiogenic shock, but with hypovolemia potentially. So, I think it could be a component. And if it's not like they're not like they were overloaded to begin with. It's not going to make that worse. So yes, I would start with a fluid bolus because hypovolemic shock will improve with the fluid bolus. Vasodilatory shock may improve with the fluid bolus. Cardiogenic shock won't be hurt by it as long as it's not like cardiogenic shock associated with valvular disease or something like that. It's more, associated with a drug causing decreased cardiac contractility. So yes, I would always start with a fluid bolus and I think that's a good way to start to see if that helps. And if it doesn't, then you might need to, consider using pressors. And so, if you start getting up closer to that shock dose, that 80 to 90 mils per kg, you really start to think, man, did I overload them? Am I going to overload them? Maybe I need to start using vasopressors. Maybe I need to start using positive inotropes. Another thing that you can do is just look at the heart. So if you were to look at these two hearts, these videos used to work, but they don't work now. But if you can look at it from just looking at these two hearts, which of these hearts do you think could use fluid and which of these hearts do you think could not use fluid?
Bottom right needs fluids.
That bottom right needs fluids for sure, right? So sometimes I'll just look at the heart and that'll give me an assessment of contractility. Is it contracting well? Oh, it's contracting well. I don't need a positive inotrope. And, is it look like a small, constricted chamber versus a large dilated chamber? Well, I'm going to, this one, I'm going to feel pretty safe to give fluids. It doesn't mean it still could have a small ventricle for other reasons. And I'll talk about that in a second. But I'm not going to hurt this heart by giving it fluids. This one, if you looked at the video of it, you'd see it's just barely contracting. I might hurt it by giving it fluids. So this one, I'm going to focus more on positive inotropes and, maybe plus or minus vasoconstrictors. But this one, I'm going to give it fluids. I don't know for sure fluids is the key. And I'll explain that in just a second, but I know it's not going to hurt because it looks like it's pretty small. And there's other things you can do, and they talk about it, like looking at the cava and stuff like that. But for me, I just, the thing I would encourage you guys to start looking at, just looking at the left ventricle. Okay, so let me just go back and make sure I didn't miss anything. Mainly fluids, bottom intros, promenates. Why do we start with fluids? We talked about that already. How do we know when to start pressors? How can we detect hypovolemia? So we talk about that right now. We can look for fluid overload, look for a small left ventricle, small cava. Like I said, I usually like to start with the left ventricle. I think that's the easiest thing to look at. You can also look for other indicators of fluid overload like B lines, pleural effusion, large cava, large left atrium. But again, start with the left ventricle. That's the easiest thing to look at. And that's what I'm showing you here. what I want to show you here is, let's just say this is I look at it, it's to say, somewhere between here and here. I look at it and the heart, has some decent size. This is what I think I'm seeing. Normal size heart. I assume that I have a normal size constriction of the vessels. What if I have a really small heart? That might mean that I have an absolute hypovolemia. That's what I have here. There's less fluid in the vessels, so I have a small heart, not enough preload. I also could have this situation here, where I have relative hypovolemia, where I'm all vasodilated, so there's less preload. So again, what I'm just trying to show you here is that a small heart like this does not always mean that it's an absolute hypovolemia. It could be a relative hypovolemia. But again, we said with the relative hypovolemia, oftentimes we'll start with fluids. So it wouldn't hurt to give this patient fluids. If it's not working, then you need to vasoconstrict it. And then a big dilated heart, again, usually, is when you have this, you're way overloaded and stuff like that. But you could have this situation, but this would be, your heart failure situation due to valvular disease or due to hypertrophic cardiomyopathy, where those systems are vasoconstricting and holding on the fluid. And you usually know if you have this because they have congestive heart failure, they have difficulty breathing, they have ascites somewhere, things like that. Versus this one won't have those things, and it will be big and dilated and not contracting very well and need a positive inotrope. And you wouldn't want to give fluids, but you might want to give uh, uh, definitely something to help the heart to contract a little bit and constrict the vessels to maintain that afterload and stuff there. One last thing, 3 stages of shock. You have compensated, early decompensated, late decompensated, right? So important thing here is that you really want to catch them in this compensated phase. That's when so if you have a high heart rate and bounding pulses, things like that, and we can talk about why you have bounding pulses later on. I don't want to go too long in this, but you in that compensated phase, you want to that's when you want to catch it. If you let them get to this late decompensated phase, organs start to fail, bad things happen. It's hard to get them back. You're kind of too late. So you really want to catch them early on here. So if you notice that high heart rate, if you notice, those bounding pulses, even the blood pressure is good, treat that aggressively, fix that shock before it gets to this phase here. And we talked about prolonged CRT and heart rate changes and all that. As you get to that late stage, you might actually get a decreased heart rate because the heart just fails. It's going to rest. Okay, well, sometimes when I'm talking about this, I feel like I'm making things more confusing than more straightforward. So hopefully I didn't. But, again, I think it's one of those talks where you look at it one time, then you have to go back and think about it and read it. It's hard just to learn it from a person. You kind of have to go and read on the articles. There's a Di Bartolo Fluid Therapy has a great section in it on shock and different types of shock. It teaches it a little bit different than I do. It focuses more on distributive shock than vasodilatory shock. But it's pretty much the same thing in my mind, although it's not exactly if you look at the definition. But I think that's a good start to read, and there's lots of different articles on there. So, what I would do, Joseph or Jesse, everybody wants to do this, is read some articles on it, and let's look at the article and talk about it. Because again, I think this is something where I can give you a lecture, it'll help you, but to going it over yourself and thinking about it and running the scenarios through your mind would help you to get a better understanding.
Nah, man, I think you did a great job. It wasn't convoluted or anything. You didn't over dilute the fluid info. It's all good.
Cool. Sometimes it's when you're teaching, sometimes when you're talking, you're like, I don't think I'm doing this well. And then somebody's like, oh, no, I'm right on it. But this one I do find, again, just because of all the little different scenarios, it's a little tough.
Yeah, it's a
Cool.
complicated subject. Yeah. I have a
Yeah.
quick question. You were talking about the like relative hypovolemic heart, like the small heart.
Mm-hmm.
Can you explain that a little bit more?
Yeah. So when they talk about hypovolemia, so it could be absolute. So this would be an example here. Oh, here. This would be an example here of an absolute hypovolemia, right? So I have decreased preload. It has to do with the concept of not just having decreased volume, but what effect that volume has on preload, or the relationship of that volume to preload, right? So, typically if you have decreased volume, you have decreased preload, right? And so the scenario here is that decreased preload due to an absolute hypovolemia or a relative hypovolemia, meaning that this would be an example of an absolute hypovolemia. There's normally, a liter of fluid in the body, and this body has a half of liter in it now. And so that half of liter in the body is causing a decreased preload or decreased ability to get blood back into the heart. Versus a relative hypovolemia, I have a liter fluid in the body, and I still have a liter of fluid in the body, but my vessels are all dilated. So now that blood is just pulling in the capillaries, and that's decreasing preload. So that's what they call more of a relative hypovolemia. And a lot of times when you first see this, if you just give them a little bit of extra fluid, you can restore that preload. But if it's really, really bad, ultimately what you got to do is give them a vasoconstrictor to get that blood out of the capillaries, out of the, pulling in the venous system and going back into the heart. Does that make sense?
Okay. Yeah, that helps. And then one
Well
more question
said.
one more question I had was when you were looking for like evidence of fluid overload, you said you can look at B lines and stuff. To
Yeah,
me, I always thought that was more of a late sign,
it
I
is a late
guess.
sign.
Okay.
It is a late sign. But, what I'll do, it's just the way I do my assessment when I'm trying to do what I call my volume assessment, right? And there are ways that we can determine if a patient is going to be fluid tolerant versus fluid responsive, meaning that, we can try and look at things that say, I'm pretty confident that I give this patient fluid, it's going to respond to it. Those things are pretty hard to do. They usually involve having arterial catheters in them. They're usually done on patients on ventilators. But if you look at them, they'll say, yes, there's a good chance that your patient, will respond well to fluids. A lot of times you got to give them fluids and just see if they respond though. But there's things that I can do that can tell me that my patient is likely to be fluid tolerant and highly likely to be not definitively fluid responsive, but highly likely to be fluid responsive. So what I'll do is, number one, to look for fluid tolerance, I'll look for any indicator of overload. Do they have ascites? Do they have a big left atrium? Do they have a B lines, right? And it doesn't mean that if they have those things, you can have non-cardiogenic edema and have B lines, right? So it doesn't mean that they're definitely fluid overloaded. But if I see those, I know, oh, they might be fluid overloaded. And so, I'm going to be a little more cautious with my fluids, because even if they're not fluid overloaded, I still should be a little more cautious with my fluids, right? And then I'll look for things that say they do look to be on the underloaded side, or the volume appears to be a little low. And so one of the things that my mentor used to teach me, the only things that you can look at heart rate, you can look at lactate, you can look at blood pressure, but none of those things tell you volume is low. Like we said, your blood pressure can be low to poor cardiac contractility, your blood pressure can be low to vasodilation, your blood pressure can be low to obstruction, right? But one of the things can be hypovolemia. So, all those systems can be activated for reasons other than hypovolemia. And how do we determine if they're hypovolemic? There's three ways that, we can look to do that. One is echo and ultrasound. The other is looking at the heart on radiographs. And the third is through a central venous catheter doing a CVP. And we don't use CVPs that much these days because they're a pain in the ass. I don't think we use them at all these days because they're a pain in the ass. But and radiographs kind of a pain in the ass to do just to look for small volume, but ultrasound is something we use frequently. And the way we do it is we look at the cava to look to see if the cava is small, or if there's no variation with respirations. We look at the left ventricle and look at the size of the left ventricle. And those are the two main ways. There's some other things that you could do too, looking at hepatic distension, things like that. But those are the two main ways that we look to see if it looks like they're hypovolemic. And if we see that those are small, then we're going to assume that they're likely hypovolemic. Now, it could be an absolute or relative hypovolemia. That's a problem. But again, if those are small, then and there's no evidence of fluid overload on my other things, then I know my patient's fluid tolerant and I could keep giving them fluids and seeing if that fluid works. And I'm unlikely to hurt them. Does it mean they'll definitely respond to fluids? No. They could be this, and I may need to still use a vasopressor, right? But it does mean that if I give them fluids and they don't have any B-lines, they don't have any indicators of fluid overload, and their ventricle small, well, fluids is probably not going to hurt them. They're probably fluid tolerant. So, and again, if I see this, they're very likely to be responsive to fluids versus if I see this, I know, hey, no, that one's very unlikely to be. They could be fluid tolerant, they could be, fluid responsive, but much less likely. And I'm not going to be as aggressive with my fluids. I'm going to switch more depressors. Does that make more sense?
Yeah, that's making sense.
So
Yeah.
again, look at the ventricle. If it's small like this and there's no evidence of overload, I'm safe to give fluids, and they're also pretty likely to be fluid responsive. They may not be, they may be here, but they're pretty likely to be. If I see something like this, a big heart, or if I see indicators of fluid overload, I'm not going to be as aggressive with my fluids. I'm going to go more depressors, and I'm going to be less cautious. The other big thing they push these days is that when you see this, give some fluids, but don't be afraid to worry about this and start early with your pressors. Because if you overload them, sometimes you can overload the fluids much sooner than we think. And maybe you want to, as you give a 1 to 2 fluid boluses, as you go to 40 mils per kg, maybe you can give them a little more if you're still seeing this, but maybe consider a pressor in there with it, because they might have some vasodilation, could use that, especially if you have reason to believe they might have vasodilation. They were given a drug, they have sepsis, whatever the scenario is.
Okay.
Okay, well, we'll end it there. I'll
All
see you tomorrow.
right. Thank you for having me. That was fun.
Cool.
Have
Sorry if
fun,
I'm yelling.
Jesse.
See y'all later.
All right, thank you.
Okay, I'll see you guys later.
All
Bye.
right, see ya.
Bye.